Good afternoon, good morning for some people who are from different geographical locations, and probably good night to some of you, or good evening. Now, I first would like to thank of course, all the sponsors for being generous in supporting our school, the Electroporation-Based Technologies and Treatment. Now, for the third year in a row, we are organizing a round table on Thursday afternoon, which is, of course, helping us in discussing what we think is hot, relevant topic. And this year, actually, we are focusing on the non-thermal ablation and drug delivery beyond the beyond the usual, I would say, therapeutic indications. When I say usual, this is, of course, for many years been cancer, but in recent years, the dominant use is really in cardiac ablation. So we're not going to be really discussing about cardiac ablation explicitly, but I don't think we're going to avoid the discussion about it. We have, so my name is Damian Miklaucic. I'm going to be moderating this round table. With me is Bar Koz, digital moderator. He's going to be monitoring the questions from the online audience, and we have a question and answers channel open, so please feel free to put questions anytime. Now, as I mentioned, now that pulsed field ablation in cardiology is taking central stage in virtually all the cardiac congresses, and that we have constantly evolving number of tools, and the number of applications, the number of patients being treated is reaching 1 million around the world, and this is only since it's 2 years basically since the first approval of the FDA device in the States for cardiac ablation. This is really something that is changing the cardiac electrophysiology. It's changing at a pace that nobody was able to foresee. Now, we see, of course, all the time new companies coming with the new devices, but not only that, we see enormous appetite for investors in this area. So I'm going to show a couple of slides. So Cardium secures 250 million to support launch of globe pulsed field ablation system. Yeah. Then, of course, and this is, of course, based on the expected or estimated market size and the enormous growth in this market, which is, making sure that this is probably the best investment you can do nowadays if you're looking for an investment. Then, of course, we see Galvanize pulls in 100 million for another application. We hear of course, the treatments of chronic bronchitis for chronic pulmonary obstructive disease. And we see, of course, the first in human clinical data that is being published with quite, I would say, good success. We see former actors in the PFA, in cardiac PFA, who are now starting companies like this one, for example, All PFA. I like the name, All PFA, of course. It alludes to we're going to all be doing PFA, or we're going to do with PFA everything. And of course, there are other companies with new indications. So treating diabetes, for example, the first in human study I would say there's a lot to learn, to do, and so on, but definitely a very interesting application. We also have a representative on the panel from a company that is targeting the thyroid nodules treatment by electroporation. And of course, we have heard over the course of the school the combination of bleomycin with electroporation for vascular malformation. And we have an interventional radiologist with us who has been this. So the nickname for this roundtable for me is really PFA, so pulsed field ablation beyond cardiac ablation. So can we learn from, if nothing else, from the business case of the PFA in the cardiac ablation, can we learn something? So I'm super happy and proud to have here with us the panelists, and we are going in the same row. So Rafael Davalos from Georgia Tech, Julie Gill from University of Copenhagen, Martin Meyering from Amsterdam, from University Medical Center, Peter Kramer from Slovenian Institute of Quality, that's notifying body, Slovenian notifying body. We have Declan Sodden from Murai Medical from Ireland, Frederic Deschamps, who is coming from Gustave Roussy, a medical doctor treating tumors compressing the spine, the vertebral treatment. Helena Cindric from our lab from University of Ljubljana, working on treatment planning. As I mentioned, Dimitri Kuhel from University Medical Center, Mitch Levinson online with us, and to finish off with Stephen Mickelson from University of Iowa, who was actually the founder of the initial startup company, which grew into from Iowa approach to Boston, to Farapulse, which was then acquired by Boston Scientific, and is nowadays the dominant PFA platform for the use of cardiac treatment. To start with, and giving the word now to Rafael Davalos, it's kind of strange because the publication on irreversible electroporation actually is 2005. So after 20 years, the IRE came into the list of the Time magazine, the best inventions, and of course the angiodynamics, the nanoknife. As you will see, there are a couple of companies who were invited but did not come. So if you're asking yourself why they are not here, I can't really tell you why they are not here, but we can definitely, we can recognize that some of them are missing. So with this, I would really like to hand over to Rafael, and please.
All right. Hey, thanks, Damien. It's great to be here. So I'm just going to start with a couple of slides just to give some background. I'm talking about IRE as an ablation method, but more importantly, just that there's different ways to do high voltage pulses in oncology. There's electrochemotherapy, where you're actually trying to keep things reversible, and you are trying to introduce drugs into that area to kill the cells. There's gene electrotransfer, which we're not really going to talk about much today, but you're actually trying to do something kind of similar, stay in that reversible regime and introduce genes to help fight the cancer. And then finally, there's irreversible electroporation, where you're trying to do this predominantly non-thermal form of ablation to treat areas while preserving underlying critical structures. So in general, for electrochemotherapy, you're placing probes into that targeted area, delivering a series of high voltage, but typically just a few pulses. So maybe 8 pulses or so to try to keep that reversible window open and get these chemotherapeutic drugs into that targeted area. Usually you're introducing drugs that are actually traditionally a little bit too large to enter into the cell. So with irreversible electroporation, it's similar in a way, but we're usually turning up the number of pulses. So we're making it more difficult for those cells to survive in that environment. So you don't need the use of the drug. You can actually just facilitate the treatment with just the electrical pulses. For this, and I want to show this slide just because you see in PFA, there's all these different probes coming out every week. There's a new device now, but they all have their a lot of different advantages. But there's different probes that have come out also in this space. I think there's still a lot of room for improvement here. We haven't moved as fast as happened in the PFA space, but there's been some development in the probe configurations. And all these probes can be used for IRE or ECT or EGT. I think something that is important to recognize is whenever you're doing IRE or reversible, you will get a region that is that's both. So in the bottom left image, that center contour, that middle ellipse, that would be the amount of IRE that you might have, and that outer zone, the outer circle, is with the amount of reversible. And then if you're trying to do just the reversible alone, if you look up in the top image there in the corner, if you're only trying to get reversible, you only get that little bit of region before you'd actually start getting some irreversible. So almost always when you're doing a reversible therapy, you're going to get a significant volume of irreversible. And then over here, I don't know if this will, oh, it does. Okay, if we start doing this kind of in vitro, so this isn't quite representative of what you'd happen in vivo, but you have, this is in between these curves, this is your reversible curve is the function of the number of pulses versus your irreversible curve. And you can see as you increase, this is your reversible window, but it's going to get harder and harder to have a reversible window as you increase the number of pulses. But this is just in vitro because the field is going to propagate out. So why, for all these techniques, why we like this non-thermal mode of ablation, I think it's because you spare the underlying structure. You can treat right near critical nerves. You can treat right near major vasculature because you don't damage that extracellular matrix. You also get this sub-millimeter line of demarcation. And that has tremendous impact for the patient. So if you're treating patients diagnosed with, let's say, prostate cancer, you can maintain continence after therapy. You can maintain potency after therapy. And this is why people are looking more and more towards using, let's say, irreversible electroporation for the treatment of prostate cancer because other therapies have many side effects. And I think one other big thing that is happening is people are recognizing as we're looking at immunotherapies in combination with focal ablation is that it turns out that these electroporation-based therapies seem to be even more impressive than, let's say, cryo or thermal therapies in inducing a positive immune response. So I think this is has tremendous potential. Here's some sample papers. This is an early study where we showed that we get with just the IRE treatment, it's difficult to do the re-challenge, but there's several papers that have come up showing that you're releasing these antigens in their native state, and you open up this window for T cell activation, and the references are there on the bottom. You see this even when you can treat the primary tumor, and you actually can reduce that metastatic burden with just treating that primary tumor. I think this is, I have one more slide here. This is, again, I think the key thing that's happening now is that when you do the ablation, let's say you're doing IRE, you release these antigens, and they get released in their native state. They don't get denatured, so you have dendritic cells coming in. You prime the T cells, and they can go out and look for the metastasis. So I think that's where we're moving now. I'm hoping in the area of using PFA for oncology applications. And these are some more references where it's been used, some incredible promising studies, not just in mice, but as well as in people, and for liver, pancreatic, and prostate cancer. And I think as this data comes out, it'll be a game changer.
Okay, thank you. So before Julie gets her word, and I think we're going to accumulate some questions, I wanted to show one thing. So first of all, I already pointed out 2005 was the original paper published, and of course you worked probably a couple of months before you actually published it. So we're 20 years now. I'm going to show you a very old picture where the first time Clinipurator, the device for clinical electrochemotherapy, was displayed. And based on the date of the photo, which was taken, was November 7, 2002, in Düsseldorf, in Germany. And there were some very young people in this picture, from left to the right. I mean, there's all of them roughly 20 plus years younger than today. So just giving the approximate idea how long ago things were already close to the clinics. So, Julie.
Yes, so I think we have to be quick today, so I'll take the first 20 years in one slide. Basically, in 1993, Luis Mir and his group published the first clinical trial with demo-type electrodes. They are now in clinical use. And 20 years later, in 2013, we had the first real commendation from National Institute of Health and Care Excellence, NICE, in the UK, that concluded that there is sufficient evidence of efficacy of electrochemotherapy for treating metastasis in the skin and also no major safety concerns. So this was huge. We have now many different electrodes, and the thing here is that cancer, of course, can occur in every part of the body. So we need an electrode that's appropriate for the purpose. And you can see here some examples. Basically, now electrochemotherapy is being used, for example, in cutaneous tumors, which was the first indication, also colorectal tumors, liver tumors, bone tumors, tumors near the CNS, and so on and so on. There's really no place that you cannot use it, and the literature is expanding. Another important thing that we have done, which has had huge impact on the spreading of the technology, is we did back in 2006 a standard operating procedure based on the first clinical trial with 50 patients. And later, as we had more experience, we invited the same authors of the first paper and also more users of electrochemotherapy to update these standard operating procedures. And as you can see, this is now a highly cited paper indicating that this updated standard operating procedure is really widely used among clinicians. And I think this has been extremely important in that you have this cookbook for clinicians so that you acquire some kind of homogeneity in the results. A second thing we've done, just to show you a little bit about what we can do. So this is an example with the with malignant melanoma metastasis treated with IV bleomycin and electric pulses. You can see there's immediate necrosis of the tumor, no difference in the normal skin, and complete remission 6 months later. What is interesting is this difference between normal skin and tumor. So you can see here the needle marks out in the normal skin, but the normal skin is not necrotizing. However, the tumor is completely dead and necrotic. And this goes for electrochemotherapy, also is found across the electroporation technologies. And there's a number of reasons which you may hear at another time when we have time to discuss it in detail. Also for larger tumors, this is a breast cancer recurrence on the chest. You can see, especially on the lower panels with a PET scan, that you can actually in one session treat rather large tumors. Another thing we did was that we started collecting real-world data. So this is the INSPECT group, International Network for Sharing Practices on ECT. We are for this paper, we were 28 treatment centers grouping all our data in a common database so that we could analyze 1,000 patients and also get a lot more out of the analysis by collecting a number of variables on these patients. And just to show you one slide, this slide shows that across different tumor histologies, we actually have very nice response rates. CR means complete response of 71%, and overall response is complete and partial responses of 86%. So this is a technology which is a platform technology that works across cancers. All we need to do is to have the right specialist and the right electrode. A couple of final slides here is that where we are working now, on top of the other two developments, is that now we are working at the European level. So the EU has launched an initiative to make sure that all cancer patients in Europe have access to the best cancer care, and a joint action network of excellence on cancer has been formed. It's funded by the EU with 40 million euros, so they are quite serious about this. There are a number of work packages from poor prognosis cancers to survivorship and so on. And this work package is about high-tech medical resources. And in that work package, 7 important topics have been chosen. So these are not the only high-tech medical resources, of course, but these are the topics that EU chose to focus on for better distribution of the technologies and also especially better patient access. If you look at the physical methods of ablation, you will find a couple of people you may know. So Professor Gregor Serse, also here, and myself are leading this domain. And what we are working on is really to identify things that we need to do in order to have better access for patients. We're working across technologies and across specialists. And the primary aim, of course, with the local ablation is primary tumors or metastasis, oligometastatic disease, which is patients that actually have disease spread, but only in a few places. You can actually still cure them if you treat these oligos, so few metastases. Also, with the new medicines like immunotherapy and targeted drugs, it's not uncommon that you have great response, but you have one resistant clone that's growing, and then you can actually save the patient by treating these resistant clones. And these are the challenges that we are working on. We are working on uneven access. We find the reimbursement paths to be completely heterogeneous, complex, and not logical. So we need clearer reimbursement paths across Europe. I would also say this is a worldwide problem. We have several specialties performing physical ablation, so there's a need for collaboration also across borders. And then we have, in my opinion, limited integration of physical ablation methods in disease-specific guidelines. So you may have it for colorectal cancer metastasis to the liver, but then you don't have it for skin metastasis, or you don't have it for something else. So we need it to be in all the disease-specific guidelines, so for breast cancer, for colorectal cancer, for lung cancer, and so on. Every guideline, you have to have physical methods of ablation. There are training needs. Also, we need real-world data. The patient group is very heterogeneous, so you have all kinds of cancers, all kinds of types of spread, and the only way to get proper data is to really have large data available. And finally, we have this complex data mix, which is really the work of big data and AI in order to gain a deeper understanding of the needs for this. And with that, I will close my talk.
Yeah, thank you. Julie, if I may, but also others. So electrochemotherapy as a combination of electroporation and the drug, it's a local treatment. Yeah, I mean, you do sometimes give, of course, the chemotherapy systemically, but it's still mainly local, and that's why you are bringing up, of course, the need for, let me say, control by adding immunotherapy.
So there's 2 types of adding immunotherapy.
Yeah.
One is you give the patient immunotherapy, you have a wonderful response, except in one site. where the immunotherapy is not working.
Okay.
And then you can actually kill that final site by a local method of ablation. The other part is that you can do electrochemotherapy or calcium electroporation and add immunotherapy. And the general thing is also that we need really to combine physical methods of ablation, electroporation-based therapies, much more into everything else we are doing. And I would add, I'm a professor of oncology, so I treat patients with all these drugs. The idea is that you have a personal care path for each patient, and you discuss this as a multidisciplinary teams. But we need to have more knowledge of electroporation-based technologies and other physical methods of ablation in the multidisciplinary teams. So where you're sitting with the surgeons and the oncologists and the pathologists and the radiologists.
Yeah. So, I mean, you have now this project. I wanted to ask you, for example, if you would need to estimate what would be the number of patients being treated that are being treated in Europe on annual basis with electrochemotherapy, what would be your best case?
Thousands?
1,000?
Yeah, thousands.
Thousands?
Yeah.
But not 10,000s?
Probably not.
Probably not. Now, you said, of course, there's a variety of patients that are being treated. It seems to be effective electrochemotherapy across the different types of tumors. But these patients are treated by very different specialists, medical doctors, oncologists, surgeons, interventional radiologists.
So the key is the multidisciplinary conferences. That's where the information about these possibilities has to be present. So we need to shape up the what's on the table when the multidisciplinary teams meet with both the oncologists, the surgeons, and so on. And these multidisciplinary conferences, I mean, in my institution, it's every day 10 patients being discussed in a multidisciplinary conference. So this has now become the centerpiece, really, in the treatment of cancer patients.
And another thing that you have here is data collection. So I know there's a INSPEC database that, of course, helps those who are part of that effort to exchange experience, discuss cases, and so on. Do you see these growing?
It is growing, and it's growing exponentially because more centers are joining. But what we really need also is to have research funds so that when we get in these new technologies, we should be required by the health authorities to at the same time upload data to databases. So there are various databases available, and these may be combined. I know that CIRSE also has a database collecting real-world data. But I'm just saying that this is the next step. So we are past the phase 2, treating 50 patients, having a nice result, and on to something which is a completely different stage.
This is now, when did the project start? This one?
The Jane project started last year, and it will run for another 3 years. And after that, it is expected that the network of excellence on physical methods of ablation will continue by itself.
Okay, perfect. Thank you. So, may I then ask Martin Meyrink is a interventional radiologist, and I think he's uniquely suited to, discuss where irreversible electroporation is right now with respect to other ablation technologies used by interventional radiologists, I would say, across Europe at least, if not around the world.
Yeah, thank you, Damian, for the invitation to give this talk. But I'd like to first give a brief comment on the previous speaker, and then I'll go to my slides. It's I love it. I took a photo because the big problem, and it's pretty much, I think it's unacceptable that patients within Europe, probably the same goes in the US, are just not able to find, the center and the physician who's actually able to sometimes even provide cure. So it's bizarre how a patient that is looking for these treatments, they do much better. And there's multiple studies showing that. On the other hand, I think that we need to do a better job. But there's one thing that we can learn from the cardiologists. I'm thinking there's several here. The cardiologists and also the medical oncologists, where I'm more involved with, they want hard evidence that something works. So I don't want to. I'm involved in several registries as well, and I love the RESPECT registry. But it will not change any of the guidelines. And doctors are critical and skeptical. But as many of you here know, the people who have to decide, is this going to be reimbursed? They are way more skeptical. A registry will not do it. So I think that there's one thing that the cardiologists do better. I'm not aware of the trials done, but in cardiology, everything has to be proven by randomized controlled phase 3 trials. And I think it's not that hard. The problem is, how are we going to? There's so many ablation techniques. Even within pulsed electrical fields, you have shown that there's dozens of companies stepping in. I think one group that is, to me, an example of maybe a way to prove it, even though there's so a multitude of energies available, is to compare standard of care, very often chemotherapy or surgical resection, to focal therapy, and let the center decide what that is. And of course, we can have a lot of discussion when the trial is positive that focal therapy is just as good or better. What was electrochemotherapy better than IRE, or what was the complication? We can do that later. But if we don't do the randomized control, I think this is why it's still a niche indication. If we don't do the proper trials, we will probably fail to get it reimbursed in the long term. And I see that problem increasing because it's not one technique, it's 20 techniques coming up. So, but I just wanted to start there. But then, to take a positive note, for those of you, sorry, I'm repeating the slides, but the positive note, if you see where we were 20 years ago, we were pretty much non-existing, only in some dedicated centers, whereas now we've completely taken over the treatment for patients with liver cancer, kidney cancer. It says 30%, but I think this is, in the process of dominating the non-metastatic, primary tumors. It's just a way less invasive way to eradicate the kidney cancer than radical nephrectomy or partial nephrectomy. And you can see the much lower numbers for prostate, lung, and pancreas. But that I think that when we have this meeting in 10 or 20 years, I don't see it going any other way. The only thing that may, endanger this, that will be for the best of the best reasons, if we find systemic therapy that is, curable. Maybe in 20 years we'll be there. At this moment, it's booming times for interventional oncology and everybody involved. Also apparently for skin tumors and all the deep-seated tumors to be in this area. Problem is that many of these techniques are not reimbursed, but even though they are not reimbursed or not in the guidelines, you can see, and I've shown you this slide, that the amount of work is already crazy. And this is why I think that from a physician's side, nobody is, how do you say that, welcoming more patients than we're already doing. So it's fantastic you have this project, because these patients should see the physician that is able to treat, that patient. I think this is the way to go to set up trials like this. This was an extremely difficult project, also politically, because you're comparing surgical two disciplines, surgery to ablation. It took, we started in 2016, but actually we started in 2006 preparing a trial like this. I'm not saying that this is realistic for all of the things we are talking about today. So we have to work out a way how and speak to the healthcare authorities. What would be sufficient evidence for you? What kind of randomized trial or comparative study would you need to get things reimbursed? But obviously, a trial like this would be a game changer for IRE if we do end up having comparative trials. You can see that within a year after publication, all the guidelines actually change. So it takes a long time, hard work, a lot of collaboration, but after that hard work, it goes super quick to get things in the guidelines. And for IRE, we've been talking about how to get it reimbursed for 20 years, but I think the answer is very simple. We failed to provide evidence, hard evidence that it's working. For example, you put this slide in. That's actually a good example. This is a rare cancer. It is impossible to do this in a single center in a randomized controlled trial. So collaboration, within Europe, maybe even global, is the way to go if you want to have a large-scale, preferably randomized study in the field of cholangiocarcinoma. But you can see that, for this cancer, we are in a subset of patients able to provide full cure. So we need to do this randomized work, because none of the healthcare authorities will reimburse it if we don't come up with hard evidence. I think it needs an RCT, but up for discussion. This is not mine, I think.
No, that's
okay.
no longer yours. So let's go just one. Let's just go one back.
Yeah.
Sorry. So you mentioned, of course, that it's difficult to change the guidelines, but then again, with a trial like you showed, it happens immediately. Now, I'm sure you're going to remember, but I think at about the same time as PFA was coming up, before it really started to gallop, the primary care, the first choice treatment was drug, and then this was changed. So it's difficult to tell whether that was the big trigger or it was not. But how do you see that? Is this something that can make the big change?
Oh, you mean in the world of AFib drug therapy as a first line? We've known drugs are toxins for a long time, and the problem is the risk to benefit ratio. Advent, of course, was run as a randomized trial, very powerful, and I think that the adoption rate would not be what it is today if it wasn't for the fact that the boldness of the investors to be able to support a randomized trial, because believe me, they don't want to do that. Made a difference. But you see the paradigm shift in such a strong way, but I think that the antiarrhythmic drugs are just, unfortunately, we just don't have any good ones.
Yeah. But it was about the same time that the guidelines changed for the treatment of atrial fibrillation.
The Vantage trial just now published for ablation being superior to drugs for ventricular tachycardia as well, and so they're going to flip as well.
And the other thing is, and Julie, you also mentioned guidelines, and cancer has a very special, for each disease, basically, a specialty, you have a separate guideline. And you have, of course, the national guidelines. And
so just to comment on that, so there's an important detail that we just have to keep in mind, which is that the heart is always the same, more or less, from person to person. So you can use same electrode, same technique, easy to do something randomized. And also colorectal cancer liver metastasis, they can be positioned a little bit differently, but you can you can make a randomized trial. If you have electrochemotherapy that works for all tumors everywhere, but you need different electrodes and different specialists and so on, then it becomes difficult to do the randomized trials, and then you need to look at data differently. So I think I do agree with you entirely that a huge randomized trial is just wonderful in terms of just settling the matter once and for all. Really, but it's not the option of every case.
No, that's absolutely true for MSK tumors and a lot of the skin tumors. You cannot put them into one box. So cardiology is difficult to compare with, but still, it's up for discussion. And I don't know if it's ethical. But in that early phase when we had electrochemotherapy, if back then we would have compared chemo alone to chemo plus, that would have been massively positive. But now it's that patient will say, no, I want to have the electrochemotherapy. So we're beyond that. So I think in the earliest stage when we think we see a benefit, for example, the IRE pancreas plus immunotherapy, this is the earliest stage. I think we should be, because then this is a phase where patients would accept being randomized. But I agree with you, for rare cancers and for heterogeneous disease where you cannot compare one patient to another, that remains difficult. Yeah.
Okay, so let's move on. Many of you know Peter Kramer, as he was the member of our lab for many years. A few years ago, he decided to change the career, and he went to, I would say, to the regulators in a way. Unfortunately, this year we could not get FDA to participate for obvious reasons, because they are not simply to work outside of I would say U.S. to be very mild. They were here 2 years ago, actually, so I was hoping that they would participate. But nevertheless, Peter Kramer is here, and I think one of my questions always is, because I don't know this field at all, and I know companies are struggling with the regulatory affairs, and they know how to deal with that. But just for us, if we are talking about new indications, if we are talking about existing therapies, but looking at the new indications, just walk us through, Peter, please.
Okay. Thank you for inviting me here, although I'm not the FDA. So maybe we are basically, so we're coming from the organization notified body, either in Slovenia or any other 50 notified body from European Union. Basically, this is the last step before you enter to the market. So all beautiful idea that we, or bright idea that we see in previous presentation, and you probably throughout the week, you have see a lot of innovative things. Eventually, you want to come to the market and then treat patients and so on. So this is just where I'm coming from. This is for European market. FDA, of course, is from USA. It exists also MD sub program, which covers a couple of different markets like Canada, Australia, Japan, also United States. So there are different programs that you need to work through and get, let's say, certificate to come to the market. Now, today, so how to start that? So how it's with new indications. So the basic idea from these regulators is that everything is patient safety, and that we somehow achieve benefit to risk of our device or our idea of treatment. So two things are crucial or important. One is how to organize organization where we developing our medical device, and on the other hand, how we organize the technical documentation and all the important things for the product. Yeah. So quality management system is one of the crucial things. So we need to have organization following some rules, some procedures, that basically we assure that whatever we do each day in the organization, either the production, either the design and development, or so how we sell the devices, how we follow the market and so on, all in the same manner with the same forms behind. So we need to establish a real culture so that everything what we are doing, that we develop all the time the same device, that we have traceability on changes in our device, because we will get through the years some feedback from the market, like in the science. You get the feedback, you try something new, and of course you need all the time, you need to have the same path through that. And this is one thing of the quality management system. On the other side, when we develop product and it's ready for the market, before that we need to prepare the technical documentation. And in this and when we are developing this device, basically, first we need to focus on our intended purpose. So intended purpose that we will cure with that device all the cancers, it's a bit rough. So We need to specify what we want to achieve, which cancer, how. So we need to limit ourselves. And then what kind of indications we want to treat. So if we have, let's say, as you mentioned before, a lot of tumors that you can, as a scientist, you see that it's efficient treatment. But in this case, we need to lower down indication. Why? Because each indication you need to somehow prove with the clinical study, which is expensive. Each clinical study, each indication regarding to notified body costs you some money. Then you need to define what is the state of the art. State of the art in the case, if your device is not present, what is now available on the market? What are the risks behind that? What are the new risks that, so everything in the development, in the production, so the risks that might appear with your device. So everything is a risk-based approach. And of course, when you have electrical active device, then you need to have some testings, maybe biocompatibility testing for the electrodes in our case, maybe some, I don't know, some material testing. Then, of course, before getting to the notified body or the FDA or whatever, we need to qualification of our device. We need to classify it so that we know in which classification we are going. And of course, what is the system? So what do we need? For instance, we have a signal generator. It's one thing. Then we have electrodes. It's basically accessory to this because you cannot do without electrodes application of electrical pulses, for instance, for electroporation. So we have now two devices. One is accessory, but you also need to classify that one. And of course, you need to write down a couple of risks that might happen with the operation, with usability, and that you put to technical documentation that it's, let's say, partially ready for the notified body. And in that mind, you just need to focus that after you get to the market, you need to follow what is going with your device or similar devices on the market. So you're basically gathering information that called post-market surveillance. So this is, let's say, some simple certification procedure with the timelines. So as I said, maybe at the beginning or forgot to set, notified body is something which is very expensive and takes a lot of time. So first of all, of course, you approach to notified body. You said, okay, application form, we are doing this and that. Somehow we sign the contract, and then the organization send the technical file. Then with this, we spread this to different, let's say, auditors, different experts, which are checking a different field, so technical view, clinical view, your device. And then after, let's say, we approach, so after the audit of technical documentation, you probably receive back some kind of findings, so in forms of recommendation and non-conformity, which means that you need to work something, maybe on the development, maybe in the production side. At least you need to, let's say, fill out or repair your documentation part. When this is approaching to finish, we have another audit. We said on-site audit, so we come into the organization to check the behavior of your quality management system. And in case that you have a subcontractor, you're not doing everything alone, so either development or, for instance, production, then we need to see the production side as well. With that, we achieve that we assure that your device is safe for the market, and you get a certificate. How long does it take? Here is our, let's say, from our notified body, which is designated in March 2023. Now we issued under the MDR about 40 certificates, and the average value is about 14 months. So we have cases where we, let's say, certified software in 6 months, and we have cases that we need for non-active devices, so let's say more than 2 years to grant a certificate. So if you want to start today with your brilliant idea and you want to come to the market and earn some money, so start early. Start with the quality management system, establish traceability of your documents, establish traceability of your changes in the development and in the production. Define medical indications, define intended purpose. It's really important. We can talk later on at dinner what is the different for the same device, from the same, but you can have different intended purpose and completely different use and completely different users. So who is the user? Gather clinical data. So use MDCG guidance issued by European Union legislation. Consult a notified body, and of course, schedule the realistic timelines and budget plans, and after that, post-market surveillance. So it's not, when you get the certificate, it's not end of the story, but you need to renovate each year. You have a surveillance audit, and you need to carry on with all these requirements. Okay, thank you.
Thank you very much, Peter. So it all sounds to me very, difficult, because I'm in academia, so finding papers and tracing the papers is not my skill, to be honest. But Declan Soden is coming from Mirai. He actually moved from academia to the company, and to the company with the medical device being developed. So, and the interesting part, of course, is the gastrointestinal tract. That is the target, Declan. So please, go ahead.
Yeah, thanks, Damijan. Great to be here. And I suppose my advice to anybody would be to hire the right people to do the quality system. I think as a scientist, when you kind of make that transition, yeah, it can be very overwhelming. You know, all of the requirements. I mean, the reality is you need good people working with you who understand that process and can put it in place. So don't worry about it, Damijan. Just get good people to work with you to do it right. I think it is frustrating, though, in Europe that it is such a slow process, the MDR process, and that the market in Europe is so fragmented as well. So there's a lot of difficulties there, I think, for innovation in Europe. Obviously, the regulation is important. It's important to protect patients, but it's just not all connecting up at the moment. So yeah, my name is Declan Soden, and I have a photo to share as well, like Damijan did at the start as well, from 20 years ago. We had the good fortune to have the SOPE Consortium meeting in Cork. I'm there on the left-hand side, a younger man, and many of the people here in the audience, Professor Mir, Professor Gell, Sirsa and Damijan, all there. But I was very fortunate as a young scientist who had a background in molecular biology and genetics to be part of this amazing consortium that was looking at the first use of electric chemotherapy for cutaneous cancers. And we've been able to take that experience and expanded it into the kind of gastrointestinal space, I suppose. And so for us as a company at Mirai Medical, we're very much focused on the use of pulsed electric fields for treating patients with gastrointestinal diseases, and specifically, as you see here, in terms of GI cancers. So, you know, when we look at it in terms of pre-malignancies, both in the upper, the esophagus, and in the lower GI, presents a great opportunity to prevent progression of disease from pre-malignant to malignant. And great healthcare savings and quality of life benefits to the patient. And so, clearly pulsed electric fields can play a potential role in these indications. And then when we look at GI cancers, there's a growing number of them. And, particularly as well, there's a growing number of younger patients being affected by GI cancers. And what's really important around that indication as well is organ preservation. And so, that's an area where pulsed electric fields can play an important role into the future. So very briefly, Mirai Medical, we have established our generator for pulsed electric fields, the ePort. It's a high-frequency biphasic generator. And the over-the-scope catheter, the Endova device, again, both are CE approved, and thankfully. And in the clinic in Europe and in Australia right now. A little animation that explains how this device works. So it's an over-the-scope device. It's got two J-shaped parallel electrodes, which give a very nice distribution of the electrical field. It's positioned, we use vacuum to grip the tissue, and then the energy, as we've been talking about here today, and as you've been learning about all week, no doubt, how we deliver these pulses of electricity to disrupt the cell membrane, to disrupt the cell, to facilitate drug delivery, or to individually just cause irreversible electroporation. It's really crucial in the GI tract. The healthy tissue preservation is very important because of the thinness of the lumen, and that's where pulsed electric fields have a distinct advantage maybe over other kind of thermal-based modalities. So to date, we have, I guess, completed a number of clinical studies. We've also established a registry for collecting the data, which is obviously important. Obviously, we spoke a little earlier, I agree with Martin and Julie, in terms of the value of an RCT, but I suppose the first step really for us has been kind of doing these smaller clinical studies and collecting kind of registry data to demonstrate the value of this. We've been able to treat patients, primarily patients with later stage GI cancers, so palliation. We've been doing it in an endoscopy outpatient clinic under light sedation, kind of outpatient treatment. We've had zero serious adverse events. We have a couple of minor adverse events in the upper GI space, but nothing major. And then from an efficacy point of view, we've been able to show this kind of excellent tumor debulking, as you'd imagine. And the big one as well, obviously, is by improving the patency of the lumen, it's really improving the quality of life for these patients. The other significant indication would be bleeding. So we see excellent bleeding cessation, which I guess makes immediate sense when you think about the vascular lock that's triggered by pulsed electric fields. But we see this is robust and long-lasting, so it kind of goes beyond a couple of hours after the immediate treatment. In terms of kind of what that looks like, this is just a nice example of a patient treated recently at King's College London. This is using calcium electroporation, so reversible electroporation treated with the Endova device, and then local injection of calcium followed by application of the electrical pulses. So in this particular case, this patient, 77 years of age, would have had chemoradiation treatment, been unfortunately unable to complete the full cycle of treatment, which is quite common. Patient had bleeding and significant pain prior to treatment. Obviously, the image speaks for itself in terms of before and after. But again, importantly, we see the preservation of the healthy tissue structures. We don't see kind of any trauma as such triggered by the treatment. Just talking then, so kind of from a registry point of view, we have the Pioneer registry, which is up and running, which is collecting kind of the evidence generated, the real world evidence generated by the use of the technology. What I did is kind of try to summarize this down or tidy it down. So when we look at specifically calcium electroporation, which is what we've been doing in the lower GI space, patients have really all been left-sided, so kind of more endoscopically accessible. It's more difficult to maneuver the endoscope and the device, the over-the-scope device, kind of particularly in cases where there's obstructive disease. We do have new catheters in development which help us to overcome that. But really kind of all the evidence we have to date is with the over-the-scope device. And primarily looking at calcium electroporation really has delivered absolutely excellent outcomes for the patients. Primarily The symptoms patients have had been around bleeding for about 3/4 of patients, constipation and pain, again, in about 3/4 of patients, quite significant pain for those patients. And we've been able to show a quality of life improvement, symptomatic relief in nearly 90% of those patients treated. And again, about 91% of patients have shown robust bleeding cessation as well. And obviously, we're delighted as well that there's been 0 serious adverse events or rehospitalizations. The other options available really for these patients might be, for the rectal cases, would be radiotherapy treatment. But that triggers a lot of kind of adverse events as well, and diarrhea and quality of life issues for those patients. So, it's really showing itself to have a lot of value. And then just a final slide here. We're progressing as well with a clinical study in patients with pre-malignant disease. So this is one of the first patients that was treated with a complex polyp. This is, again, using the Endova device, using the ePOR generator to deliver kind of pulse field ablation. So no calcium in this instance. This is just the electrical pulses alone. You can see the before and after image. It's, again, very nice vascular lock. It's very obvious in this particular instance. And then the follow-up at 6 weeks. So we have 24 patients enrolled in that study right now. It's ongoing. Again, no serious adverse events or no complications or any issues really reported to date, which obviously that's a huge first step as well. So exciting times. Great to be here. Great to kind of share thoughts and ideas, and delighted to be still involved in this space 20 years later. So thanks, Damajan, for the invitation.
Yeah, thank you, Declan. So it's just a couple of questions for those who are not totally familiar. So when you refer to calcium electroporation, of course, it's a combination of calcium with electroporation. And calcium comes in which form and how it's injected?
Calcium gluconate.
Okay.
So it's kind of lower conductivity. Obviously, Julia's done all the excellent work with calcium over the years. But yeah, calcium gluconate has worked really well. So yeah, that's injected locally into the lesion, and then the pulses are applied.
Yeah. One of the things that you mentioned, of course, is that EU market is so fragmented. Can you elaborate a little bit on this? Fragmented because of the approvals or because of access to reimbursement in different countries?
Yeah,
what exactly?
Sure, yeah, exactly. So reimbursement is different across all the jurisdictions. So, that's one factor. I think another factor would be kind of the clinical adoption. Can be difficult if you generate evidence in Denmark. For instance, a lot of the early calcium electroporation work endoscopically we did in Denmark. That wasn't necessarily adopted immediately in other jurisdictions. You have to kind of do more clinical studies and kind of build the evidence. So that can certainly be challenging. Kind of it's almost jurisdiction by jurisdiction. The doctors in their country only trust kind of results or data, particularly with the new technology. It can be, and obviously being a small company as well and not being a recognized brand perhaps is a factor in all of that as well. But yeah, I mean, in Europe, it's very different in Italy to what you have in Spain, to what you have in the Netherlands or Denmark or Ireland in the UK. Different business cases required to get that reimbursement. I mean, it's interesting, say you look at France, the birth of electrochemotherapy occurred in France, but I mean, how many electrochemotherapy cases occur in France? And I think it is a difficult market to enter, as I understand it, in terms of reimbursement, and there's challenges there. But, so I mean, each country in Europe is very different and presents different challenges.
So one of the things that you mentioned, and I think it's really important, you said organ sparing, organ preservation. And I remember Jerry. I met Jerry first time when he was actually giving a talk, and this was the same conference we were attending with Gregor when we discovered, electrochemotherapy. To be honest, Jerry Sullivan was working on esophageal cancer, and that is pretty devastating disease. Are you anywhere close in treatment of that?
Sure. Yeah. I mean, there's patients being treated with the Endova device for esophageal cancer. It's a more challenging anatomy. It's restrictive in terms of endoscopic application. The patients that would tend to be referred are very late stage, so they're obstructive. There's concerns around if you expand that balloon dilated that you might run the risk of perforation. So it's a very tricky cohort of patients to be involved in. We are developing a new electrode, which kind of gives us greater accessibility. And I would be very excited to see that indication be realized. So I think, we've seen great safety data with the use of positive electric fields in the lower GI space. And I think, it kind of holds great promise that we could translate that very well to the upper GI space as well.
And I think going a little bit back to what Peter said. So you said, this indication and that indication. Peter said indications. Which indications are the right one? Julie said. So is it we need to be clever enough to get the right indication, and once we have a good case and so on, and then we can think this will spill over to other indications, or I'm being naive? I'm just Can you leverage your experience,
Sure. Yeah.
and now when going towards the esophageal cancer treatment?
Yeah.
Is that easier now?
No, I mean, I guess it's a cost. It's a money factor, isn't it? I mean, it's the size. You're asking people to invest to pay for that RCT, which will take 5, 6, 7 years to execute, with maybe no guarantee that the results are going to be positive in outcome. So you have to convince them that the market size is significantly large. And I think, Martin gave a great presentation earlier, but, investors don't like that time frame, do they? How long that takes, even if the outcome is, encouraging that it's going to be positive. I think we could all of us here in this room today would be positive that the outcomes would lend in the right direction. But the difficulty when you kind of break it down to a very kind of one indication, and a particular stage maybe of disease that you might treat, it's actually the numbers are maybe not attractive to investors to put the money in to pay for an RCT.
Yeah.
That's a challenge.
Because I'm in academia, I have no clue. What kind of money, what kind of investment are you talking? What is the cost of this kind of randomized clinical trial that you ran, for example?
So the commission, that's exceptional. We're about to write an editorial. We did that for less. So don't take this as as an example. Less than $1 million. Normally, a trial is like 300, 600 patients. But correct me if I'm wrong. It's closer to 10 million than the 1 million. I can tell you later how we did that. But I think between 6 and 10 million would be realistic. Yeah.
Well, based on what I showed at the beginning, virtually every company now that comes up with, we're going to treat something with PFA. In the first round, they get 40 millions. In the second, they get 100. In the third, they get 250 million. At least in California, it seems that's the general, or I got it wrong.
Class 3 medical devices in general cost about 100 to 120 million US to get across the finish line based on data from about 3 years ago. And so you need to raise a lot of money. Clinical trials in my space tend to be, in that 10 million to $30 million range. I don't know what you're spending on your clinical trial, but I imagine it's not cheap. But there are a lot of cheaper ways to go. Obviously, if you can get an investigator-initiated trial and you're running it, but to run a device-focused clinical trial for the purposes of regulatory approval and market approval, i.e. adoption, because the randomization really helps with that. It's very expensive. This is the most expensive hobby I've ever had.
Okay, good. Well, thanks. So we're jumping a little bit, because Declan said, starting off with electrochemotherapy, then of course replacing bleomycin with calcium, and then you ended up with electroporation only. Yeah. So I think the next panelist is Frédéric Deschamps, and he has, of course, an extremely interesting story to tell, I think. Frédéric, please.
So hello, everyone. I am an interventional radiologist. I'm the head of the Department of Interventional Radiology at Gustave Roussy. So talking about my experience in the management of bone tumor metastases for sure, we are very familiar with thermal ablation. That's something that we are doing a lot. That is something that we during the past, but still now, something that is very effective to treat lung metastases, bone metastases, liver metastases. And we have started with radiofrequency ablation with a limit in terms of efficacy of 2 or 3 centimeters. That's something that is now well adopted as a technique. Then we move to microwaves that allow us to make larger ablation area, then cryo with several probes, and we can obtain very big area. So we always focus on how we can get larger and larger ablation margin. So we were very happy with that. And then why do we need electrochemotherapy? Is it a new competitor in this tools of treatment that we have to treat the cancer? And I definitely think that electrochemotherapy is an option that is of great value because there are some tumors that we cannot treat using thermal ablation technique or the very similar techniques that are radiotherapy. The problem is that usually these tumors are close to critical structures that we can destroy with heat or freezing. So we need something that is probably more selective as a treatment. And that's why when Luis came and explained this technique, at the beginning we were not very interesting because we focus only on thermal. And then we realized that there is something with this technique that is of great value, is that it will use the mitotic death. And that's a new area of selectivity for the tumor cells. We have the possibility to focus, to be selective in terms of geometrical area with the insertion of our electrodes. And then within this area that we electroporate, we have the selectivity of the cells that multiplicate, and thanks to the bleomycin action, and probably less toxicity to the non-divided cells. So when we think about this, it's very interesting to have this ratio and to avoid damage to non-divided cells that are in the area we electroporate. And thinking of that, that make the theoretical advantage to treat tumors that are close to structures such as the nerves, the skin, or the spinal cord. And that's why we move to that, not because thermal ablation is not effective, but because thermal ablation is toxic to these non-tumoral cells. So that's why we move to this kind of presentation. You can see on the left a tumor, the white part that compresses the spinal cord. This is an epidural metastasis of the vertebra that compress the spinal cord. And you can see here the problem. We cannot treat the part of the tumor that is close to the spinal cord without any toxicity to the spinal cord. The standard treatment here is palliative radiotherapy. Usually they only perform 8 gray, something like that, but it's only palliative. It's decompress a bit, but then the tumor is still viable and it progresses again. If we think about thermal ablation, for sure we can destroy the tumor, but we will also destroy the spinal cord and the nerve. But then the idea of electrochemotherapy is to create an area where we electroporate the cells, thanks to the current, and then the bleomycin will make the work and destroy the dividing cells. And this is what we obtain on the left. We decompress the metastases on the right, sorry. So we were very exciting here for that. We have started 5 years ago, and it's very easy to start because this patient has no other option than paraplegia and nothing is possible for them. So we have performed this study. We took all the patients, it was 40 patients, consecutive patients that has already been treated with radiotherapy because it's the standard treatment. And then they have this compression disease without any option but this new treatment that we have tried, which is electrochemotherapy. And you can see that we have huge response. It was amazing. We obtained first a pain relief because on this 40 patient, the pain was 7/10 before the treatment, and at 1 month it decreased to 1/10. And among patients that had an MRI after that, we observed, like in these two cases, a complete response, 46% of complete response. That is unbelievable. That's something that we couldn't imagine before. So very, very exciting treatment, not a competitor with other technique because there are none. So the problem that we face, and that's probably something that we need to improve during the next years, otherwise the technique will die, is that we cannot predict in a very predictive way how the current will go across our electrodes. We imagine that the current is going directly, but in between there are fat, there are tumor, there are bone, there are cortical, there are fat. So it's difficult to predict. And if we have a too high amount of voltage crossing the spinal cord, we could have this kind of complication that we have in 7.5% in our study. This is a paraplegia related to the high current that goes through the spinal cord, and very similar to what we can see in the literature when patients suffer from electrical burns or lightning strike. So the key for us as a clinician is to keep the efficacy of this technique, but then to control the voltage and to control the geometrical configuration of the current in order to maximize the voltage in the tumor and have low voltage in the spinal cord, at least a voltage that is not toxic. Very similar to what the radiotherapists are doing. Radiotherapists perform radiotherapy also in the spinal cord, but there is a threshold that should not be overpassed, otherwise there will be a myelopathy. And this is probably the same with the current. So knowing that, knowing the conductivity of the tissue that are here, knowing the anatomy of the tumor, then we need to make some study, to have some, I don't know, softwares that help us to predict how will be the current between our electrodes before delivering the treatment, or think about other options. I don't know. That's something that is of great interest. Maybe work on geometrical configuration in order to increase the voltage when we have this convergent approach. High voltage far from the spinal cord and lower voltage close to the spinal cord. That's something that we are doing in real life, but something that we should analyze. Something that we are also working on, but need more works, is what I'm name stereotactic electrochemotherapy. This is similar to what radiotherapists are doing. They radiate in different direction in order to minimize the effect on the surrounding tissue and to maximize the effect at the center. So now we perform several positioning of our electrodes with low voltage in order to have at the end an accumulation of pulses in the center of the tumor, and finally less exposure to the spinal cord. Work on something that I've learned recently, the different pulses that could be less toxic for neurons than for tumors, or works on the electrodes. Yeah, so just an opening question, but for as a physician, that's the key to make this technique a bright future it deserves. It's definitely something that is of great value, but we have to go through this problem to make it as a first-line treatment. For now, it will remain as a last-line treatment till we don't manage this problem.
Okay. Thank you. Thank you very much. So before going to the next panelist, who actually has an interesting title, the predicting the unpredictable. I think you have used that words, yeah, and it's just by chance. The title and the order. You said that you're used to, and you have been using before, the ablation techniques, different ablation techniques. So for you, it was not really difficult to take it. So that's one thing that I'm keep hearing, that the cardiac ablation was so simple because the heart is every time the same. I don't think so, but the other thing is, I mean, I don't think electrophysiologists, cardiac electrophysiologists would agree that you can treat each patient in exactly the same way. So the other thing is, of course, that they just replaced, one catheter energy with another catheter. So again, I think it's a simplification. Or again, you have taken something which is electrochemotherapy, replacing the IRE. So you were not really stopped by not being able to use that. So the question is how to make more people to make this decision.
To move to electrochemotherapy,
For example.
yeah. Now there is in the community there is a huge interest for that. People are very interesting because that's patients that we didn't treat before. And in clinics, that's patients that are very frequent. So now people are interested in that, but they always ask the same thing: how would you do this case? And for now, it's there are no consensus because for now we don't know exactly the best way to do that. It's still exploratory.
So for us, the first time when the paper by Gasparini came out, the very first paper, which was, the very first case that was documented, done in Bologna by electrochemotherapy, treating, a patient who had a severe pain, but then after a month, no pain. But the other thing was that also the tumor and the life expectancy of this kind of patient was really poor, but the patient was alive for 4 years still, if I remember correctly. So that is kind of close to the, close to the miracle. We don't believe in miracles, obviously. We know it's science behind. We know how bleomycin works, how it kills, and so on. And this has been thoroughly studied at Gustave Roussy, if nowhere else. Yeah, and so now, somebody said before we should make treatment available for patients, at least within Europe. I mean, we claim that Europe is, it's kind of free market. I mean, joint market. There's a free flow of goods, of material, of people. We can move, we can work wherever we want, and so on. Yet when it comes to healthcare, I think we are far from there. Yeah, I don't think I know, for example, what Martijn does, and then I say, oh, I just want to be treated in Amsterdam, and I don't think that goes. It works like that, or I would like to be treated at Gustav Roussy with Frederick because he knows how to do it, and this is something that is. I don't know why this is the case, but I think we have to address it at one point. I don't know.
I think that we are the exceptions where we do get international patients, but I mean, we all agree this project may help.
Okay.
We need to guide the patients to go to the centers where they have specific expertise.
Yeah.
But we do actually forward patients to Frederikshavn for electrochemo from the Netherlands. But it does exist, right?
Yeah. Okay. So we just need to, So anyway, patients who have the other thing is, of course, you mentioned these are patients who have no other options. Yeah. And of course, sometimes when they, especially with cancer, when patients come too late, it's too late. Yeah. If they would come earlier, it would be so much better for the outcome of the treatment. So just going towards, we see some images where to place, how to place the electrodes, and so on. So I'd like to really introduce Helena Cindric. So we have been working in our lab for, towards treatment planning. I think you've done it for your PhD. And before, Bart, there were other people working on that, and Helena was actually the last one working on that and defended PhD last year or
3 years ago.
3 years ago. Wow, the time flies. Yeah. Okay, so please, Helena.
Thank you. So I come from an engineering background, and today I'm going to talk how to predict the unpredictable through the use of the numerical modeling. But first, a little bit of background. So electroporation is inseparably tied to electric field. After electroporation, we get a very diverse biological response in tissue based on the electric field strength that is experienced by the cells in the tissue. So in the same volume of fraction of tissue volume, we will get different fraction of cells that are dead or reversibly electroporated or perhaps even unaffected. So to simplify things and for practical use, we introduce the concept of the electroporation threshold. So by this, we assign a threshold value to our electric field strength, above which we assume that all cells in our tissue volume are dead. So this is called the lethal electric field threshold, or LIT, or at least reversibly electroporated if we're aiming at technologies for drug delivery, such as ECT or GIT. Now, by applying this threshold value to our electric field distribution in tissue, we can essentially simulate the effective treatment zone. Now, of course, these thresholds need to be experimentally determined because, unfortunately, there is no universal threshold. The thresholds differ between different tissue types and also between different treatments, or should I say, treatment protocols. In clinical applications, our ultimate goal is to cover the whole clinical target volume with sufficiently high electric field, so that is either exceeding the lethal electric field threshold or the reversible electric field threshold. So for that, we need to know the electric field distribution in the tissue. Electric field distribution is primarily determined by the electrodes that we are using, but also by tissue properties, and different tissues have very different tissue properties. So the interplay of these two makes it very hard to predict the distribution, especially in complex anatomical locations such as the spine. Now, in some applicators, such as these fixed geometry applicators, the linear and hexagonal handheld applicators that you're probably familiar with, the story is pretty straightforward. We have the predetermined electrode geometry and pulse parameters. So in this case, it is quite easy to predict how our effective treatment zone will look like. But for example, in deep-seated targets, such as liver tumors, these long monopolar needle electrodes are used. And these are highly versatile electrodes. We can construct very different electrode geometries. And of course, it makes it more difficult to imagine how the electric field will look like. On top of that, unlike in fixed electrodes, here we can have different insertion depths of the electrodes, and this will in turn affect how the field will distribute. And also, because we need to take into consideration the anatomical constraints, we will usually have some sort of needle deflection. So it's almost impossible to predict the electric field without using some form of computational tools. Now, numerical modeling is a computational approach that allows us to solve very complex systems of equations. So we can predict, for instance, electric field distribution, tissue heating, also chemical reactions. And we can simulate very realistic anatomical geometries. And this is why the role of numerical modeling is increasing in electroporation research. And amongst more notable applications are patient-specific treatment planning and development of new clinical applications. But more than that, it can accelerate research through in silico experiments and promotes transfer of knowledge between different research groups. Now I'm going to focus on two of these applications, and the first is patient-specific treatment planning. So we can construct three-dimensional numerical models that are based on patients' medical images. So these are either CT or MRI, which we segment. And our goal is to use electric field calculations of electric field in our model to determine the optimal electrode position and pulse parameters. So these are the voltages that should be applied to different electrode pairs in order to complete our goals. And our goals are, first and foremost, complete coverage of the clinical target volume. This is, for instance, the tumor with a safety margin. To ensure, of course, the technical feasibility of this procedure, and also to cause minimal damage to surrounding sensitive anatomical structures such as vessels or nerves or spinal cord. And numerical modeling can help us with that. Here is an example of a study that we did with the clinical center in Regensburg. This was IRE ablation of different hepatic tumors, both primary and secondary. And here we showed that by using a patient-specific model and even very basic optimization techniques, we can significantly reduce the thermal component that is present in IRE ablation, thereby making these treatments more safe and perhaps more accessible to patients that would otherwise could not benefit from this treatment. Now, there are still several challenges that we need to address before computer-assisted treatment planning for electroporation-based treatments can be introduced into clinical practice. First, I would like to point out that if treatment planning is employed, and that's computer-assisted treatment planning, it's not that common. It's always prepared on pre-interventional images. And this can be a problem if these images are too old. So real-time treatment planning would be preferable. Nevertheless, even if we have planning before or during treatment, we absolutely need the integration with navigational tools because of the technical difficulties of placing these electrodes for deep-seated targets. Third point, all models need to be validated, and currently this has only been done in a retrospective manner for electrochemotherapy and IRE ablation. Therefore, we would like to do that in a prospective clinical study. And lastly, there is also no standardized endpoint assessment method currently. And this is why we need these longitudinal imaging studies that show us how the targets, so how the treated ablation sites change during the time to see which one is the best in order to quickly assess how successful we were in the treatment. Now, patient-specific models can be used to develop new applications, and this was a very good succession of our talks. You've seen this application in the previous talk by Dr. Deschamps. This is the electrochemotherapy of spinal metastasis with transpedicular approach. And by using numerical modeling, it is very possible to calculate the electric field distribution in this complex anatomical location that is the spine because we can introduce all of these tissues of interest. We can include the spine, all the nerves, the tumor, the bone, the surrounding fat tissue that is not shown here. And we can then precisely calculate the electric field distribution. We can also include heating simulations if we are doing IRE, for example, and we can evaluate how the safety and feasibility of such treatments. So with this, I will conclude with a few thoughts. So numerical modeling can help us enhance the safety and efficacy of existing treatments, but more, it can extend treatments to new, interesting anatomical locations and can guide the development of applicators and new clinical applications. Thank you.
Thank you. So, Frederick, I mean, you were showing pretty much the same images or pictures as Helena did. And Martin, I know you were, I've seen you position the electrodes, how precisely and where, and you are trying to identify exactly where the vessels are and where the tumor is. So maybe you two, any comments on this? Any thoughts?
No, that's the key to have this kind of software to prepare the procedure. The best would be to have it before and then as a confirmation in the operating room, because that's the planning we want to do, and then there is the reality. Sometimes we hope that our electrodes can be parallel or exactly, and we cannot succeed in making exactly as a software, but to prepare the procedure, that's really interesting. And then to adapt the procedure, that's the key.
Yeah.
Like Elena mentioned, this is actually what we need. I mean, if you saw that slide that I presented earlier for thermal ablation, 20 years ago, we had more than half of the tumors occurring, and now we're close to 0%. So it's steps like these. So my question to you would be, it would not be possible to fly in Helena for every case. So how would we be able to do this?
We can use Zoom, for example.
Okay.
But there's direct flight, as you realized. Yeah, I mean, it's always good to take the computer off the airplane when you take off, because But that's for later. That's a story for later. So everybody's going to ask you what's the story. But now it's a happy end story.
Thank
so
you for
it's
mentioning
fine.
that.
It's a happy end story. So but that also goes back to I remember when IRE was introduced, and it was introduced as a non-thermal irreversible electroporation. And then, of course, because it was introduced as non-thermal, some physicians, they took it literally, yeah? And because it's non-thermal, then you can deliver more because it's non-thermal. And of course, I remember there was I think, editorial or a paper or a case description where they've done a treatment of prostate cancer, I think, and they have damaged severely the structures, the sensitive structures, the bundle of nerves, and so on. And this is something that, of course, also the calculations, the numerical modeling helps us. And Helena, just remind us, you spent some time in New York at the Memorial Sloan Cancer Center in trying to reconstruct some of their cases. And that was very interesting because the outcome was what?
Yeah, we were, in that study, we were investigating as well the colorectal liver metastasis in the presence of metallic clips that are usually present after the resection. And we were using these models as the calculation of field and heating as well in order to evaluate whether these clips present
The surgical clips,
if they present contraindication and for local tumor progression. And we found out that it's possible that these clips that are in the vicinity, on the border of the tumors, that might be shielding the inside of the clip from electric field, which might cause local recurrence in the vicinity. But I'm not sure what you were.
Yeah,
wanted to-
the side result was really that there was up to 70% of the tumor that was actually treated
the
by
thermal part.
thermal
Yeah, that's true.
ablation rather than electroporation. Yeah.
And that was also the case in the Regensburg study. They also had quite a big portion of the tumors that were treated with thermal ablation rather than with IRE, because they wanted to be sure to really cover the whole tumor. And that was also the case that I showed when we reduced with post optimization. The thermal component is because they used 6 electrodes and electrode retraction, because the tumor was rather large, and they really wanted to cover the whole tumor. And it was really most of it was heated to really high temperatures in the end. So just by reducing this retraction and lowering some of the voltages, we were able to produce the same coverage and the same electric field, but significantly lowering the heat.
So what Raphael said at the beginning is that whenever you do the reversible, if you want to have a meaningful area of reversible electroporation, you're going to have some irreversible, yeah? But you will also have some thermal damage. It's almost unavoidable. So we have the whole three. And of course, now if we get too close to the sensitive structures with the electrodes, then of course it's not necessarily that we're going to electroporate. We can even heat up to the extent that we're going to damage. So we are, I think in this respect we need something. But then we come back to Peter and of course to experience of companies, because that starts to become a new product, a new medical device that needs to go through the regulation. And whenever we were presenting this results and this possibility to calculate to companies who are providing you with devices and the electrodes and so on, they simply didn't seem to be interested in going through the painful, regulation process. So I think that's another, I would say, hurdle that it needs to be somehow taken, into account.
Is this available?
Sure.
The quick question, Elena. Is the software?
It's not a software. It's really a knowledge that we do. Yeah, but yeah, we
build the software.
Yeah.
As Damian mentioned, this would have to go hand in hand with the development of the devices, because otherwise you would have two separate medical devices that would both have to be certified. Yes.
Yeah, but you have in this case 2 medical devices.
Yeah. But
doesn't matter if it's developed by the same. Oh. Okay.
So just going a little bit private, you remember when I was visiting you, I was telling you we can do some calculations and stuff like that. So we can go back to that discussion again.
One more thing.
Yeah, sure.
We would love to develop the software, but the problem is that we are a faculty of electrical engineering and we don't have access to patient data. So we are constantly prowling and searching for medical collaborators that we could work with.
Yeah, thank you, Helena. So, now, the one indication that is steering up a lot of excitement is about vascular malformation. We had yesterday here Tobias Muir from UK, who presented cases that they have done and so on. Very well received. We have today Professor Dimitri Kuchel here from University Medical Center. So, please.
Yes. Our data is not that extensive, I'm also interventional radiologist. I'm dealing with this pathology for more than 20 years. And in Slovenia, we are lucky that all those kids mostly come to Slovenia, to our center. So I see majority of them in the Slovenia. So vascular malformations, these are abnormal formations of blood or lymph vessels, and they're mostly congenital, so we are mostly treating kids. However, they can be also acquired, and the incidence is about 1.5, and Slovenia is really slow. However, small. However, since they are concentrated all in Ljubljana, we see quite a lot of them. And they can be arteriovenous malformation, venous, lymphatic, or capillary. As for the treatment, the main difference is that how fast is the flow in the malformation. Treating the low flow is much simpler than high flow, and we are with electrochemo, we are treating mostly low flow. If you see that so many options are for the treatment of one pathology in medicine, it means that none works well. Mostly what we do up to now, you see that foot is sclerotherapy. And we repeated the procedures, and we had a lot of recurrences, especially in larger lesions. And I was familiar with the patients since they were coming every year or every few years. And so I watched the kids grow. And what did we use? We use sclerovein. It's a thing they use for varices, for enlarged veins. Sometimes we used alcohol, but alcohol is very, very dangerous. And to get more volume, we mix it with CO2. So at the end, we got that sclerovein foam. And then we were alerted that there is a best. And here we apply electropulses with bleomycin. It's a reversible thing. And we are treating for the moment low flow malformations. So it means venous and lymphatic. Fortunately, majority, like 80% of all malformation or even more, are low flow. Dr. Wolgemuth has a huge center for arteriovenous malformations, probably one of the biggest in the world, and he has a huge experience. And he published some data with very, very good results. So the average reduction of the malformation was almost 90%. We did not get to that result yet. However, a majority of people had symptoms improvement. These things are partly aesthetic. However, many times they are really functional. And these are his data. This thing is really a game changer in low flow vascular anomalies. And we started it in 2024. We treated 22 patients. Up to now, we treated more. We planned to treat 2 this morning. We treated 1. The other one we did not treat because we thought it's not really a arteriovenous malformation. And you see the average age was like 19 years, and majority of patients were female. 4 had previous operation. Operation in these things does not work well because they cannot extract everything if these patients can be operated at all, because sometimes the arteriovenous malformations are located in the areas that are inaccessible to surgery by means that they might do really a lot of damage. We used it in 4 patients with previous sclerosations, and majority of the patients had first treatment. The mean size of the malformation was like 40 milliliters. And we did some diagnostic imaging. We used general anesthesia, local injection of bleomycin, and then electroporation. It looks like this. It looks quite bloody, but it's not really very bloody. And this is colic instilling bleomycin, and then we use probes. We used many different probes because there were many different lesions on different body locations. And you see that we use really a small amount of bleomycin. And these are our results. If you look here, this is prior, and this is prior to the treatment, and this is 3 months after the treatment. And this is another case. You can see also this is before, and this is after. And 1/3 patients, you see this is before, and see there is a marked reduction of the lesion. Of course, results in medicine are not 100% okay. You always have complications. This was before, and this was after the treatment. We did necrosis of the lip. However, this happens also with previous treatment, so it heals then, and it's not really a problem. However, in medicine, you know, if you are sitting on the couch, you don't have problems. If you are working something, then of course you get problems. We analyzed some of the data. Majority of the patients did not come to control MR. However, we received almost 2/3 of reduction. In 3 patients, we have no change in the lesion. So in 2, we repeated the procedure and did a biopsy. Perhaps it's not a vascular malformation. We do MRI before. MRI is not histology, so there are things that look similar but might be different. However, what is important, we treated mostly patients, symptomatic patients with pain, with problems, and in all patients we reduced symptoms. So, as I said, it's really a promising new method. We have good short-term data. We don't know about long-term data, and that's something to be seen. In some patients, we have no effect, and of course, there is still no reimbursement. So,
thank you. So, it seems you mentioned the word game changer for these patients. You said you've been treating these patients in Slovenia for 20 years.
Yes, there was with methods we used. We do it always in a multidisciplinary way. I collaborate with plastic surgeons, with pediatric oncologists. They know about many of these things, and these patients come to them. Of course, we got some effect also with those sclerotizing things. And then we sometimes combined it with operation. So it was easier for surgeons to extract majority of the change. However, so marked results as with this, we have not seen up to now.
Can I ask?
Sure, Martijn.
I saw a similar presentation from Afshin Ganji, so I'm getting more and more enthusiastic.
Yeah, Ganji.
Because you said it's not reimbursed. So just out of curiosity, do the patients pay? Does the hospital pay? How does that work? How do you deal with that?
Slovenia has a great system. Everything is paid by the hospital or by the state. Patient pays nothing. So if you do it in public center, hospitals are always in negative. However, patients get anything they want. Slovenia is, I think, quite unique for doctors. It's really freedom. I don't know if there is any country that allows you such a freedom of choosing material and treatment for your patient.
And especially if you're coming from a big hospital, which is the biggest hospital, then even if it really goes in negative, it still will not fail.
But we are owned by the state, so
Yeah.
the state should bankrupt if we would fail, and it will not.
I'm wondering about the national debt here, but
Not
okay.
important.
Yeah. we don't worry about that. We have people we have hired people to do that actually. So it's government, the ministers, and so on. So they do a great job. They take care of that. Okay, so this is, I would say, it's another rising star as a treatment, steering a lot of interest and excitement, and it's moving a little bit away from cancer and so on. In a way, it's not malignant, even though it's
No, it's not malignant. However, it can be progressive and it can be very devastating for the kids.
and it can
The big ones, they can even do heart failures. Then there are thrombi that fly to it might be little.
Okay. And Declan also mentioned that one of the indications that they're going after is non-malignant, so pre-malignant polyps, I think you said, something like that. And we have now Mitch Levinson from Pulse Bioscience is joining us from California. So Mitch, tell us your story.
Great, happy to share my story. So I'm Chief Strategy Officer for Pulse Biosciences. I've been with the company for 11 years, since the company was just being formed. I came on as its first board member, helped to bring on the rest of the board and the management team. And 4 years ago, I came inside the company to be the Chief Strategy Officer. Just at a high level, Pulse Biosciences has a nanosecond PFA platform, and we're currently working on 3 different applications, with others going in the background as well. But we're going to focus today on the thyroid nodule application. We also have these programs in cardiac surgery and in electrophysiology, but we won't spend any time on those today. Let me say before you click the next slide, back up one, and just looking at this console was specifically designed to be very versatile and be able to handle multiple applications. It's got software controls over all of the parameters. It's got a nice user interface with a touch screen, so it can accommodate different user environments as well. Okay, next slide.
Next slide.
Can you turn the volume up?
All right.
Next one.
Yes, good. So NSPFA, nanosecond pulse field ablation for benign thyroid nodules, is our first commercial application using this percutaneous electrode. And you can see that percutaneous electrode picture there. It is a bipolar electrode. It has a distal electrode. You can see at the tip a little insulating spacer, and then there is a proximal electrode, and it creates a small ablation zone about 1.5 centimeters by 1 centimeter ellipsoid. Next slide. So thyroid nodule ablation is a really good example of the value proposition for IRE, but for NSPFA in particular. And just to review the anatomy here on the right side, this is an axial view of the patient. You can see the trachea in the middle, and the thyroid wraps around the trachea. And these nodules can often be in the lobes on one side or the other, and often in the posterior section, and you can see all these critical structures. You can see these critical structures where you've got the recurrent laryngeal nerve, the carotid artery, the jugular vein, vagus nerve, the esophagus, the trachea itself. You've got muscle tissue there, and as well as skin. And so it's difficult to do this type of procedure with thermal ablation. Although it's done, it's not done in the United States very prevalently. because of the risks and the skill level that's required. You can see with the ablation probe, the idea here is that we create these ellipsoidal ablation zones. The image isn't quite accurate because those ablation zones should be overlapping to ensure treatment of the whole nodule. That nodule is, the outlined greenish shade there. So there, also, when you treat these in the United States, standard of care is thyroidectomy or hemithyroidectomy in some cases. But of course, then you're losing function or at least partial function of the thyroid itself, which is a critical organ. And it's not considered to be safe or effective to excise just the nodule itself. You have to take off a whole lobe or the entire thyroid. So, and we talked about thermal ablation. Okay, next slide. So the you can see the console here, and again the percutaneous electrode. Just to point out, the ablation cycle is 8 seconds. Part of the advantage of using nanosecond PFA is that it has much reduced nerve stimulation compared with longer duration pulsing, and we don't have any need for cardiac synchronization. So we can do very rapid cycles, and we can move from one cycle to the next. Also, it requires much less energy than typical IRE because of its mechanism of action, disrupting the intracellular organelles as opposed to operating primarily on the outer membrane. And so we're not near any thermal thresholds. So again, we can do these treatments very rapidly. Next slide. And just click one more time for the other side. So I just wanted to just to emphasize these are the typical advantages you normally associate with IRE in general in this space, because thermal ablation is the only other type of ablation that's being done so far. We often are compared with thermal ablation, and I don't need to run through all these advantages. You're well familiar. Other than to note also that these treated nodules don't develop a fibrotic ball, which is one of the major side effects that is undesirable in this application. It's one of the side effects that you get with thermal ablation that we don't see any of with nsPFA. Next slide. Let me describe a little bit the first in-human clinical feasibility study. This was just published in the last couple of months in the Journal of the American Thyroid Association. And the study overview here is this was performed in Italy, Dr. Stefano Spezia. This feasibility study was divided into 3 cohorts, if you can see in the lower left there. The first cohort was a treat and resect study, meaning that patients who were already undergoing a thyroidectomy were treated during that thyroidectomy procedure, and then the tissue was removed during the thyroidectomy, and then we could evaluate it histologically. In cohort 2, we performed isolated ablation zones so we could do some dose ranging as well as sizing of the ablation zones. And cohort 3, we treated 5 patients for their full nodule, and then we could see what the efficacy was, both in terms of symptomatic relief. And symptoms here I didn't discuss, but when you have thyroid nodules, the reason that they're particularly problematic is they're benign, so that we're not worried about the cancer, but we are concerned about compressive symptoms in the neck. So we can get difficulty either breathing, sleeping, swallowing, pain. Turning the neck can sometimes be painful. So these compressive symptoms can be resolved over a very rapid period of time, and I'll show you that on the next slide. So let's look first at this chart on the left. What we see in the x-axis is the number of weeks post-treatment up to 1 year, and on the y-axis is the percent volume reduction. And of course, 100% volume reduction would mean that the tumor completely disappeared, and anything less than that is a shrinkage. I'm hearing some background noise now. And echoing. Did somebody turn on their? Looks like Clement. Did you turn on your speaker, your microphone? Okay, thank you. So on the in this are you guys hearing an echo?
No, we're fine.
You're fine there. Okay, fine. I'll ignore it. So the you can see on the plot we have very rapid volume reduction where we see over 2 to 4 weeks post-treatment, we get the majority of the volume reduction. In 3 of the patients, you can see on the top, went up to about 80% within 4 weeks, and then gradually improved beyond that. Those went between 80 and 90% volume reduction. The symptoms were resolved within those first 2 to 4 weeks. You'll see that there are 2 patients that only saw about 50% volume reduction. Those were the very first 2 patients ever treated with this technology, and Dr. Spiezia said after those treatments that he was being very hesitant and was not treating all the way to the capsule and only treated about half the volume. And we, of course, see that here. One of the patients, the one with the black line there, elected to be retreated at about 6 months. And after the retreatment, joined the rest of the group with very good volume reduction. The patient with the red line had all of her symptoms had resolved, and she was satisfied, and even with only 50% volume reduction, elected not to have a second treatment. So it's a really good representation of the type of repeatability and predictability of the volume reduction, and we associated also the volume reduction with the symptomatic relief. Next slide. Here's a good example that it's sometimes hard to see these on photos because when they're on the lateral sides of the patient, you can see them moving up only dynamically when they're swallowing or moving their neck. This is a good one to see because it was right on the isthmus in the front of the neck, and you can see the volume reduction in just 30 days. You can also see that on the ultrasound looking out to 12 months. We didn't have any serious adverse events, and the the patient satisfaction was very, very high. All the patients were extremely satisfied with their treatments in this study. I will also say that we have now launched this commercially in the United States. We've treated over 200 patients in this in this application. With very, very good symptomatic relief, volume reduction, and no serious adverse events. So we're off to a good start, and we'll be expanding our commercialization over the next year. Next slide. Okay, that's it. Thank you.
It's the Pulse Biosciences. Thank you. So just a quick question. You mentioned, of course, the publication is the one which led me to ask you to join, and it was just recently published. But you already said that you started the commercial treatments, and you mentioned 200 patients being treated. In which time frame?
Yeah, so we started a pilot commercialization about 1 year ago with just 9 sites.
Okay.
And we, during that pilot, we treated a little under 100 patients. And then over the last couple of 2, 3, 4 months, we've expanded to commercial, the commercial sites. I think we've got maybe 15 on board now. So those numbers are beginning to ramp up.
So this is now with respect to, I mean, I don't quite, I'm not sure I understand, because So the treatment was performed, the study was performed in Italy. You have started the commercial treatment. Where's the approval of the treatment?
Yeah.
Is this
Yeah, no,
FDA
good
approved or
question.
not?
It's only cleared in the United States. We have a 510K that we got last year, about a year ago, for our 18 gauge device, which is the commercial device that we're using. It's not cleared anywhere else,
Okay.
just in the US right now.
Okay. So that means it's not going to be available. Go ahead, Martin.
Very interesting concept. I know that a colleague of mine, they do a lot of thermal ablations for the thyroid. So I'm going to ask the obvious question. I'm guessing this is way more expensive. Are you foreseeing a trial comparing the two? Because I don't think that there are a lot of nerve injuries when you do thermal ablation, if I'm correct, but I'm not in this field.
Yes. No, excellent question. And in very skilled hands, the procedure, thermal ablation, can be performed safely. There are low single-digit percentages of nerve injury with thermal ablation, but that's really because of the high skill that is being deployed. Only very few centers are using it around the world. In the United States, there are really just dozens of centers that are doing this on a regular basis with thermal modalities. And because of the critical structures and the thermal spread, they often will leave portions of the nodule behind because they're too dangerous to be able to treat the entire nodule. So often these patients have regrowth. On the order of 20% of the patients need to have a second procedure. Within a year or so, they still, and some of them even, will grow over several years and then have to have another procedure or even a thyroidectomy. Also with thermal ablation, because there is so much scarring that results, performing the surgery is much more complicated after you've done thermal ablation than it is before, if surgery is needed. And that's something that we don't see at all with NSPFA. So there are some significant advantages. We also believe that we can democratize this procedure and have physicians not requiring that level, quite that level of skill, and be able to do a thorough, more effective, and safer job in this application.
Okay. Thank you. Thank you, Mitch. Thank you very much. So let's move to the last panelist, and then we can wrap up the discussion. So as I said, Stephen Mickelson was the starting up of the PFA. I heard of Iowa approach back in 2000. I don't know, 14 or 12, 14?
Yeah.
And actually it was in South Korea at Jeju Island.
Oh, yeah?
Yeah, so pretty interesting. So go ahead, Stephen.
Yeah, great. Thank you very much for inviting me. It's a lot of fun to talk about pulse field, electroporation, fulguration, whatever you want to call it, DC ablation. I was here at the Piron. That's where I met Damian for the first time, and that was in the early days of Iowa Approach. I'm an electrophysiologist, and I've been working in pulse field since about 2011, from my point of view. Cardiology has had the benefit over the last couple. So this is not a talk about cardiology. We're going to talk about other applications of pulse field and the excitement for the future. But the reason I'm going to talk about cardiology is over the last decade, there's been an enormous investment in cardiology that is almost unprecedented. Maybe more than $10 billion in R&D and acquisitions, and trying to understand how to apply this in the heart. And in that period of time, we've learned a lot about what makes it work and where there are problems. And there's a lot of opportunities. Previously, every cardiac ablation was performed almost I mean, there's some lasers here and there. There's some ultrasound. There's a few other smattering of other things, cryo, etc. But pretty much most ablation was done by thermal ablation through radiofrequency heating of tissue. Problem is that the natural history of tissue healing didn't work very well. It was great, but it would take 90 days. You would get microvascular congestion. You would have some interstitial hemorrhage. You'd have this final kind of contraction phase. You get hyperplasia. There's a lot of things about it that we didn't like. And this is all well documented. The lesions weren't very pretty. It was hard to get good energy transfer, etc. But pulse field or electroporation, irreversible and otherwise, and is primarily a metabolic injury. So you're disrupting the cell's homeostasis mechanism. It has a membrane for a reason. You get rid of that, you can no longer maintain gradients, and you end up eating up ATP in the energy cycles of the cell. PFA also results in better tissue healing overall because since you don't get microvascular disruption, you're able to bring in your immune cells, you're able to take away cellular debris, you're able to do that without having to relay down new collagen and intracellular structure. And so there's huge advantages there. And most pulse field lesions in cardiac tissue are almost fully healed by 2 weeks, maybe 30 days at the most, whereas RF is 90 days and sometimes as long as a year, depending what you're looking at. Here's an example. After a decade of playing with pulse field, we're able to get gigantic lesions in the heart. These lesions, this is coming from a single, 2.5 millimeter tipped catheter and it's over 2 centimeters wide. This can be delivered in seconds, and it's primarily an electric field mediated injury. But we could do the same elsewhere once we kind of know how to make probes and we know how to deliver pulses, and you saw amazing work from a lot of these people. What I get excited about is, the geometry matters. And we're right at the beginning of understanding how that geometry can play. Here's the difference between what an electric field, the ablation threshold is kind of that green line as predicted by, a bunch of guesses. And it's modeled, but you can see that one is a unipolar application where there's a patch on the outside of the body and then there's a catheter. And the other one, same voltage, but in a bipolar application. You can also take 2 catheters and put them in the body and fire off between the 2 catheters. Now, you could do that for any application you can think of because there's no such thing as unipolar, really. It's all bipolar. But the nice thing about that is it compresses the field and you can get very focal ablation and targeted ablation if you can sandwich your target in between the 2 things. This is one of the first pieces of ablation tissue I've ever did. And one of the things we noticed is my pathologist at the university said that I don't know if these cells are dead. Because this is just 2 hours afterwards. Steve, I don't get it. It looks at edematous. There's a bunch of extravasation of red blood cells. I see a bunch of immune cells in there. Don't know what it is. But if you let it heal over the course of 14 days, we started noticing a lot of stuff. Well demarcated lesions, preservation of the nerves, the fat, the vasculature, the collagen. We did a whole bunch of scanning looking at we're not replacing collagen, we're keeping the same collagen, even though we have full resolution of the lesions. And these are the early days of IO approach. This is some atrial tissue from the right atria, just to the side of an ablation lesion. And this is what the ablation lesion looks like 14 days later. Notice something about this. This is really kind of cool. Like nerves, like bundles, they're there. There's fat cells. These bloods, arterioles, they have intact smooth muscle. And for a while, everyone thought, there's got to be some kind of selectivity that's going on there. There's something special. Well, you can ablate smooth muscle. You can ablate, structural cells. You can ablate skin cells. You can ablate them all. You just got to turn it up. It's just that the cardiac cells are exquisitely sensitive to ablation. And the reason is because the cardiac cells have a huge basal metabolic rate. You can't just stop pumping blood. So you're constantly going through ATP. As a matter of fact, 60-70% of ATP in the heart is just constantly being cycled just for the contraction alone. The rest of it, 30 to 40%, is to maintain negative inward potential in those cells and to maintain sequestering of the calcium in the sarcoplasmic reticulum. So you have two proteins that are in the membrane that if you depolarize the membrane, i.e. if you electroporate it and there's no longer a gradient, all of a sudden you activate sodium potassium ATPase, which just starts eating up all your ATP. And when we look at the natural history of tissue healing in these cells, the other part is the sarcoplasmic reticulum with calcium ATPase. So before I could afford to do large animal studies and have animals, die, I got to move fast. Here's some electron microscopy between the ablated tissue and this tissue 3 hours later. And you can see this is normal sarcomers of cardiac cells. This is you can see E lines, M lines, some of the structures are there. You may not be used to looking at that extracellular space, very edematous on one side, not so edematous on the other. You can see gap junctions, you can see mitochondria, huge edematous mitochondria loss of architecture. You can't see it very much there. But this is something I noticed back in 2012, which was all the granules here, those are glycogen, and they're all gone on that side. And that's because they got eaten up. So if you look at the difference between different types of adipose, smooth muscle, cardiac muscle, it's just as easy to ablate or electroporate adipose as it is to ablate any cell in the body. That's the electric field strength. But boy, cardiac muscle loves to die because it eats up all its ATP and it necroses. So lots of opportunities out there. You've already heard people taking targets that are non-cardiac targets and ones that aren't just the deadly cancers, but like going after the pre-malignant like pedunculated growths that could lead to cancer. Now you can expose the immune system to those cells and it can process them, going after a couple, there were a number of low-hanging fruit kind of targets that are out there. I think Pulse Bioscience, Mitch, didn't you guys start as a derm company? If I remember right.
Yes, we did.
Yeah.
Yes, we did.
And so there are other targets besides, now the excitement about cancer and all the permutations of the ways that we can get different probes and all that stuff. I'm super excited. Mm-hmm. So that's my presentation.
Yeah, thank you very much. So I thank you, of course, for sharing this with us, the early work and being here. So one of the things, of course, that we have seen in the course of the development of the PFA in cardiac ablation is that there's a number of companies that are developing devices. And of course, there are electronic companies that are developing devices for these companies. So all of a sudden, when we enter the field, the critical question that Gregor was always asking me, when are you going to develop a device that we can use? Yeah, and of course I remember Luis having a special device that was developed for them to work in patients. So now, I mean, there's abundance of these devices. So it's not really an issue to build a device or get a device or buy a device. And I think the understanding is also better. But there's the drivers, I don't know, the enthusiasm that we heard and that was shared. Is that enough? Is it going to fly? I mean, it should. I was convinced electrochemotherapy, when I saw the graph of, increased cytotoxicity of bleomycin with just adding 100 microsecond pulses, I was sure this is going to be like a 2-year job, maybe. It's more than 20 years. It's more turning into 30 years and plus. Yeah. So it's really, and Julie you mentioned thousands of patients. Yeah.
40.
40? Is it 40 already? Yeah, my math was never. Will be. My math was never good. That's why I went to electrical engineering. Okay, so any thoughts?
Well, I think I think we heard it earlier today that one of the biggest challenges is from a regulatory point of view. If you want to enter the market, you have to kind of have an indication because you're gonna sell the product and you have to make enough money off the product to cover the cost of development and running the trial. But like that is a very difficult thing to overcome. If you say, look, I need to raise $10 million to run the proper trial so that I can get the label on here to say that this treats cancer, or that I get a label that says this is good for treating uterine fibroids or something like that. That becomes a challenge. Now, in cardiology, of course, we're just used to everything being a class 3 device that you always have to do that on. But I think outside of that motivation, when you have the standard of care there, like there's the inertia, to overcome the inertia of the standard of practice is very hard, and to raise money to do that is very hard. And I think that's been because it's pretty clear that the data that was being generated almost 20 years ago now was very compelling.
Yeah, I think in PFA they did a couple of things really right. They said, what are our big advantages? And it was safety and speed. And they really made sure that it was safe by not thermally damaging things and such. So I think that's one thing we need to, if we're going to get the funds to do a trial, even though the market for PFA cardiac is much bigger than oncology, you have to think about what are the convincing outcomes. So it's going to be, that safety and that optimal immune response, if that's what you're doing, to do it in combination with something. But you really got to focus on what outcomes would be convincing.
Yeah. We have a number of people online. Do we have some questions that we...
Yes. So one question that is for Mitch Levinson, it's for thyroid ablation. Since PFA is a different ablation energy modality, what was the predicate pathway used for 510K?
Yeah, we were able to use our own device as a predicate for that soft tissue ablation because we already had the FDA clearance in dermatology. And that was really our strategy. It was to start with dermatology. It's an easier regulatory pathway. We were able to demonstrate the mechanism of action and its utility, and then be able to use it ourselves as a predicate.
Okay, thanks. Is there another one?
Yeah, and we have another question that says, what could be the role of real-time assessment of irreversible ablation zone in monitoring and titrating PFA?
I'll just say that's one of the biggest complaints I hear from clinicians. They don't know when to stop. So that's why they'll deliver maybe 1,000 pulses because they're not sure that they're done.
That's one of the difficulties, because when you do the thermal ablation, you see it. Yeah, I mean, with IRE you don't see it. Yeah, and this is one of the things that I've seen. So I think, Mitch, you showed us the data, and in the first patients you were titrating the dose and removing the tissue and looking at 2 hours roughly. Helena was pointing out that there's a need to determine when is the right time to look at. And I know that in cardiology, when you look at 2 hours, you can neglect the damage to esophagus. If you look at 1 month at the chronic time, you don't see any damage because it healed up by that time. And only recently, finally, they've done the study where they actually showed that there was damage, which healed up in 2 weeks. So what is the right time? And you talked about, different pulse parameters having a different dynamics of cell death.
Yeah, I mean, I think that's something that has to be studied for the different parameters. I mean, I remember some of the first IRE studies that were done. think work because the tissue actually healed itself. So we waited too long. So I think knowing when to look is important.
Yeah. I remember when doing experiments when I was spending time in Louis' lab, looking at the zone of irreversible electroporation in liver. The first thing was to actually determine how many days after the treatment is the right time to sacrifice the animal and excise the lesion, because if we did it at 5 days, we didn't see anything, just a small scar. Yeah. So eventually, it turned out in rabbit to be 3 days, for example, to get a very nice lesion. But it's also going to be dependent. What is the dye that we use? What is the tissue that we use? The staining and so on.
Well, the question of real time procedure planning, especially given the diversity of targets that we're talking about. I mean, rectal cancer versus going after kidney cancer, liver cancer, the pancreas. All those require different types of probes, different types of geometry, architecture, pulse planning, etc. I imagine, in cardiology, there are a couple of companies that have been started. A really interesting French company, Enhard, I think it's the name of it, uses scans and make predictions about where to ablate for VT. Same thing might, procedural planning, real time, I think is possible. Boy, I imagine it's a little bit of a lift.
Okay, so with vascular malformations, when do you expect to see the response?
We are following these patients really closely. We do MRI 3, 6, and 1 year after, and from that we will
3
see
months.
First 3 months after, and then 6, and then a year to see where. What will happen to this necrosis, and so we don't know.
Okay.
We don't know, and this could be important because that's how we could follow the patients, and perhaps the necrosis will be larger in 6 months than 3 months. So perhaps the results will be even better, but we don't know.
Maybe
Martin?
just a quick comment, because for the liver and the kidney, it is possible to use confirmation software because it's a non-enhancing. The area that you destroyed is the microvasculature, as I've seen many times today, is gone. So it's a non-enhancing area, and you can plot that over the tumor similar to thermal ablation. Cases like electrochemotherapy, etc., then probably we need to figure out how to do it to make it MR compatible. But in the liver and the kidney, there's a way to see it real time and to see if you are complete. And then maybe to add to that, in the study I've shown, the Coldfire 2, it was only 2 hours, and you could see the complete ablation zone. This was based on TTC, but maybe you have an idea. Vitality stain that comes from cardiology.
Yeah, I think this.
So you can see the effect in 2 hours actually.
Yeah.
Yeah, that's pretty standard, I would say.
Yeah.
It's early, but pretty standard.
Yeah, we couldn't wait for days with the patient open and surgery.
Yeah, no, but just to be honest, you wouldn't see with TTC staining, you wouldn't see nerve damage, for example, at 2 hours.
Okay.
Yeah, even if it's there, you would need to use immunohistochemistry or something like that. So that means that you don't see everything. Yeah, so that is quite a challenge. Yeah.
Plus, if we are moving out of oncology, long-term effects will be important in everything else what we do. So this patient should be monitored and followed.
Okay.
Yeah, we had some unanticipated complications in cardiology, early days of PFA. Of course, there's a lot of misinformation in those days. But some of the things we discovered, and I think we, the Royal We, as a medical society, is the hemolysis that occurs from repeatedly ablating through the blood pool, because the electric field is constantly ablating those red cells and they move on, red cells and they move on. And so we're seeing some sequelae coming of that, and vasospasm, transient and otherwise. several mechanisms. Those, from me, I at the time in the 2010 to 2015, I would not have predicted those. I should have thought about it, but I didn't. Same thing could happen.
It's interesting. You said you see there's the microvasculature damage. It's really, it can be even transient, to be honest, because you see the contraction, so the contrast agent does not enter. So that's one point. So the other thing is we've all seen it in experiments long time ago, that of course you stop the blood flow, the perfusion, quite immediately. In vascular malformations, do you see the because of the pulses, do you see the blood flow being reduced?
It's difficult to say. However, we do a lot of punctures with the needles. However, the patient do not bleed very much. They do, but not much. However, these are low flow malformations and they don't bleed too much anyhow. However, the feeling is that there is some reduction of the bleeding, yes.
Because that was also observation, Gregor, you remember at the Institute of Oncology when surgeons were treating liver tumors during the surgery. And so they were expecting bleeding because of the puncture, but there was no bleeding or minimal bleeding. So that is also, and of course they became a little bit whitish. Do we have some more? Yeah.
Just there is another thing that happens in vascular malformation is the edema.
Okay.
They swell. Probably whatever we do, it swells. So it's very difficult to determine what happened by needles, by electro, and there is another effect of the edema. So I think during the procedure, it's difficult to say what are you doing and how large is the area you are affecting.
So patients are, this is in hospital treatment, they stay in hospital?
In hospital, they stay in hospital for a day. We adopted some analgesic protocol, which was very strict and very strong. However, we did not see a lot of pain after. And all the patients for the moment are done in general anesthesia. That's why they stay in hospital for a day.
Julie?
Yeah, so just connecting to a few things. One way that you can actually immediately see the success in your treatment area is MRI, diffusion weighted MRI, and that goes directly back to your edema, that you have immediate edema, especially in muscle cells actually. They will, by the electroporation, take up water. And I think that's also a main cause for the temporary constriction that you see in the arterioles in the heart, is the initial reflexory constriction, which is a spinal reflex, and then followed by compression due to local edema, which will then resolve as the sodium-potassium pump gets going again, and the homeostasis is reestablished.
Okay. So, Mitch, one question I wanted to ask you before, during the pre-treatment, the patients, the sedation, or how are patients treated with respect to pain and discomfort?
Yeah, great question. Doing a percutaneous treatment in the neck is anxiety provoking even without any energy. These patients, when they are, if they're fully awake, and with RFA, they need to, or any thermal modalities, they really need to be awake in order for safety reasons. Because if there is any effect on the recurrent laryngeal nerve, they need to detect that by vocalization by the patient. So with NSPFA, we don't worry about the nerve injury, and there's no reason the patients need to be awake. Although the first 100 or so patients that we did were treated just under with local lidocaine injections, and they did fine. They did fine. Some of the patients were got to be quite anxious during the procedure, although our nerve stimulation is much less than microsecond duration pulsing. We still do get some twitching of the neck, which can be somewhat alarming to the patients, and so we have now moved generally to light sedation using IV.
Okay, thank you. So this is a last chance, I would say, for the panelists, but also anybody else for any, echoing and so on. Please don't open a new topic entirely, because we are coming to an end. And I would like to thank, of course, all the panelists. I would like to announce that there's going to be the recording of the round table. It is a lengthy recording, but there are always a number of people who could not, take time to look and listen at this time, and we always get much more viewers afterwards. So it's going to be available online in a couple of days, as the two previous are available. With this, of course, thanks to the panelists for coming, for being part of it, for the audience here and online, and of course to our sponsors. So with this, I would like to thank you all. Thanks.